Hey everyone, and welcome to this explainer. All right, let's just dive right into this. Usually when we think about medical ultrasound, the goal is getting a crystal clear picture of the anatomy, right? We actively try to filter out all that visual static. But when it comes to lung ultrasound, that static, those visual reverberations and crazy artifacts we used to think were totally useless, they're actually our absolute most powerful, life-saving diagnostic tools. So today we're going to decode the static and master lung ultrasound together.
Here's what we're covering today. First, we'll hit the basics of lung ultrasound, then move on to reading the normal lung. From there, we'll tackle B-lines and pulmonary edema, spotting a pneumothorax, and breaking down effusions, pneumonia, and consolidation. And finally, we'll wrap up with integrating ultrasound into care.
All right, let's kick things off with Section 1, the basics of lung ultrasound.
Before we can start reading the static to save a life, we kind of need to know how to turn on the radio, so to speak. Your setup is absolutely everything here. You've got a few options for your probe: microconvex, curvilinear, or linear, usually running between 4 and 7 MHz. You're going to keep your orientation marker to the left of the screen and map out topography zones 1 through 4 on the patient's right side and 5 through 8 on their left. But listen, here is the literally most crucial step of the whole process: the settings. You have got to turn off tissue harmonic imaging, or THI. Harmonics are designed to clean up an image by getting rid of artifacts. But for lung ultrasound, we need those beautiful diagnostic artifacts to show up, so turning off harmonics is absolutely mandatory.
Okay, let's talk about our very first visual metaphor, the bat sign. When you place your probe on the chest, you're looking for the upper and lower ribs. Now, those ribs cast these dark acoustic shadows downward. Think of those as the bat's wings. Connecting those two wings is a bright white horizontal band. That's the hyperechoic pleural line, or the bat's body. Finding this bat sign is your home base. You always want to anchor yourself on this structure before you go hunting for any pathologies.
Moving right along to Section 2, reading the normal lung.
To really spot when things go wrong, we have to establish a rock-solid baseline of what a healthy lung actually looks like. And that starts with our primary normal artifact, the A-line. Beneath that bright pleural line of your bat sign, you'll see these horizontal parallel reverberations repeating downward at equal intervals. Those are your A-lines. They indicate a totally normal, healthy tissue-air interface. Basically, you're looking at the healthy echo of the pleural line just bouncing back and forth.
This becomes incredibly clear when we switch our ultrasound from standard 2D mode over to M mode. In 2D mode, you see the lung physically sliding back and forth right at the pleural line as the patient takes a breath. But M mode captures that movement over time, which gives us the brilliant seashore sign. It's a perfect metaphor. The chest wall tissue above the pleural line is stationary, so it draws these straight horizontal lines, like waves in the ocean. But below the pleural line, that sliding, breathing lung creates this granular, static pattern, just like sand on a beach. So waves above, sand below. Seeing that seashore sign confirms healthy respiration.
All right, Section 3, B-lines and pulmonary edema.
Let's shift gears into a much more urgent clinical scenario and contrast these two critical lines. We know A-lines are horizontal and normal. B-lines, on the other hand, are these vertical, laser-like bright lines shooting straight down from the pleural line. They don't fade. They go all the way to the bottom edge of the screen. And, crucially, they literally erase your horizontal A-lines as they sweep past. Plus, they move in sync with the lung sliding. When you see these vertical B-lines multiplying and clumping together, specifically if you're catching more than 3 per rib space, that is a massive red flag for pulmonary edema.
The data from Martindale and colleagues on this is just staggering. When we're trying to diagnose pulmonary edema, a traditional chest X-ray gives us a sensitivity somewhere around 51 to 65%. Honestly, not great. But ultrasound? It jumps to a 94 to 98% sensitivity, with specificity hitting up to 99%. It absolutely crushes the traditional chest X-ray. For identifying pulmonary edema quickly and accurately, ultrasound is without a doubt the superior modality.
Now for Section 4, spotting a pneumothorax.
When the stakes get even higher, like a life-threatening collapsed lung where literally every second counts, we have to rely on a definitive diagnostic checklist. Diagnosing a pneumothorax, or PTX, isn't just about finding one weird artifact. You have to verify this very specific combination of what's missing and what's present. You need to see A-lines. You must see absolutely no B-lines. You're going to observe a complete loss of lung sliding and a loss of the lung pulse, which is that subtle cardiac movement usually transmitted to the pleura. And finally, you are hunting for the ultimate smoking gun,
the lung point. Let's bring back M mode for a second to really see this. Remember that healthy sandy beach of the seashore sign? Well, look at the dramatic shift when there's a pneumothorax. Because the lung is collapsed and isn't sliding against the chest wall anymore, the granular sand completely vanishes. The whole M mode readout turns into these perfectly horizontal parallel lines. We call this the barcode sign, or sometimes the stratosphere sign. It proves a total, alarming loss of lung sliding. The healthy dynamic beach has just turned into a rigid, static barcode.
So what about that smoking gun I mentioned? The lung point. This is literally the exact physical location on your screen where the collapsed lung, the part showing that rigid barcode sign, abruptly transitions back into the normal, contacting lung that still has the seashore sign. As the patient breathes, you can physically watch the boundary of the lung collapse sliding in and out of your field of view. It's incredible. If you find the lung point, you have 100% confirmation of a pneumothorax.
A quick word of warning here, though. Do not get tricked by mimickers. Not every vertical line is a real B-line. A true B-line moves with respiration and wipes out your A-lines. But you might bump into Z-lines. These are just short vertical static lines that sort of fade out down the screen, and they leave the A-lines totally intact. Seeing a Z-line actually implies there is no pneumothorax. You also want to watch out for E-lines. These start way up at the skin or the subcutaneous tissue, not down at the pleural line. E-lines indicate subcutaneous emphysema, which means there's an air leak outside the lung itself.
91%. That is the sensitivity of ultrasound for detecting a pneumothorax, and that's backed by a massive systematic review from Al-Raji and colleagues. Think about that for a second. Compare 91% to a standard chest X-ray, which hovers around a 50% sensitivity. That is literally a coin flip. If you're relying purely on an X-ray in a fast-paced trauma bay, you're potentially missing half of your pneumothoraces.
Let's move to Section 5, effusions, pneumonia, and consolidation.
For our final set of critical pathologies, we're looking at how fluid and consolidation profoundly alter the acoustic windows of the chest. This gives us three really distinct signs. First up is the shred sign. When a lung is consolidated from pneumonia, the border between the infected, solid lung and the healthy, aerated lung looks super irregular and jagged, like it's been shredded. Next is the spine sign. Normally, air in the lungs blocks you from seeing the spine above the diaphragm. But if pleural fluid builds up, that fluid transmits sound perfectly, and suddenly the spine becomes clearly visible above the diaphragm. Lastly, the curtain sign. A healthy lung moves over the diaphragm like a closing curtain. If that dynamic sweeping curtain motion is disrupted, you are definitely looking at pathology.
95%. Honestly, it's hard to overstate just how massive this number is. Lung sonography gives us a 95% sensitivity for diagnosing acute pneumonia.
And let's look at the data from the Borscher study to really back that up. When diagnosing acute pneumonia, sonography sensitivity sits at 0.95, while the chest X-ray is way behind, at 0.60. But I want you to pay special attention to the negative predictive value at the bottom there. 0.67 for ultrasound, compared to a pretty dismal 0.25 for the X-ray. It just goes to show, once again, that for frontline acute care, ultrasound vastly outperforms traditional X-rays in catching these diseases.
Finally, Section 6, integrating ultrasound into care.
We can really summarize the entire philosophy of this explainer using the rule of threes. To truly master this, you need three distinct skills. 1. Image acquisition, actually placing the probe, making sure the eye is off, and finding your batsing. 2. Image interpretation, knowing a C-shore from a barcode, an A-line from a B-line. And 3. Image integration into care paths, taking that static you just interpreted and making an immediate real-world clinical decision. Snapping the picture is really only step 1.
To quote Dr. Greg Hall from The Skeptic's Guide to Emergency Medicine, bedside ultrasound has 3 distinct skill requirements: image acquisition, image interpretation, and image integration into care paths. I love this quote so much because it drives home the point that ultrasound is an active, dynamic clinical tool. It's not just some imaging request you fire off to a technician. You are the diagnostician, working in real time.
Which brings us to our final thought for today. You've got the visual dictionary now. You know the science, the lines, and the staggering accuracy rates that make this tool so absolutely vital. So the real question for all of us is, how will you integrate the power of the static into your own clinical pathways to accelerate diagnoses and save lives? I really hope this explainer has given you the clarity and the enthusiasm to pick up that probe and change the way you practice medicine. Keep exploring out there, and we'll see you next time.